So rather than sitting around your TP, in pre-industrial times or whatever structure you were living in, you would walk through the forest and you would try to fix your gut. You would try to fix the health of your body. So now people no longer do that. They run to their physician. And their physician doesn't know much about nutrition. Their physician doesn't know how to make their gut do better. So what they do is almost always put them on a psychiatric drug.
Podcasting from the base of Lake Tahoe in the eastern Sierras comes the Medicine Wheel. We are a group of progressive physicians seeking solutions and enlightenment while surfing the seas of big data and summiting mountains of research in an effort to make the practice of medicine more personal and medical knowledge more accessible, and empower you, the listener, to be as healthy as possible. Now, the Medicine Wheel.
Welcome everyone back to the Medicine Wheel. This is Dr. Sean Devlin, and I'm here again with Dr. James Raniolo, a friend and colleague of mine who's graced us with his presence and his knowledge. He today is going to talk a little bit about mental illness, neuropsychiatric issues, and some topics including functional genomics and looking at genetics in medicine in general. Please welcome Dr. James Raniolo. Welcome.
Yeah, thanks, Sean. I appreciate you having me back. I had a lot of fun last time, and I enjoy just kind of spreading some of this knowledge that we have.
Great, fantastic. Again, I know we had a little introduction with our last interview about where you came from and how you ended up in functional medicine. Talk to me a little bit about how genetic testing and what functional genetics means to you, and then let's dive right into mental illness.
Sounds good. So I think especially in the functional medicine kind of environment, my practice is a little bit atypical. I don't really do the age management stuff. I've always been attracted to getting the strange cases, the bizarre ones, the ones that nobody else can really seem to get a handle on. And I have a bit of a tenacious brain where if I am stuck with a challenge and I need an answer to find somebody, very frequently I'm kind of the last option that they have when they've seen 6-8 other clinicians before they see me. So I usually don't stop. And our basic evaluations usually look at lifestyle, diet, nutrition, hormones. And when we're doing that, you kind of get to the point where you can resolve most people's issues pretty effectively. And then you get to a point where the people that are coming to see you, their symptoms aren't resolving. And at that moment in time, once you get there, you can either say to yourself, "Hey, this person is just crazy. They're a confabulator. They're a manipulator. They're looking for secondary gain," or you can make a decision to dive deeper. And even every single time I've ever been at that level, I've always decided to dive deeper. So when everything is fixed, their nutrients are fixed, their diet's fixed, there's no spiritual crisis, I started doing genetic analysis. And amazingly, when I do genetic analysis, you would find these incredibly convincing solutions and convincing answers to why these people have these bizarre symptoms. And in doing so, once you understand the exact genetic and biochemical mechanism, very frequently you can identify a way to body hack with the knowledge that you gained in order to help alleviate these symptoms. So over time, I started doing small genetic panels, and I'd find some answers, oftentimes using some snip testing. And then I started doing larger panels, doing some of that. And I've gotten to the point now where I do high-end full exome testing, using next-generation analysis, looking at every single protein encoding genetic sequence in somebody's entire body. And then on top of that, we actually are developing high-end mathematical algorithms and computer programs that actually look through the multi-genetic associations to find the commonalities between these diseases. And you can actually fully identify the underlying cause of just about any disease I've ever been able to look at. So that's kind of what I do with functional genetics. And using that, we can often take something like a neurodegenerative disease and find an adequate solution to it, to the point where we can stabilize the neurons to the point where there's no further degradation in function. Occasionally, we can get them to the point where they actually start, getting a little bit of function back. Same thing kind of goes with heart failure. We can, usually find the reasons that somebody might have, say, what we traditionally called an idiopathic cardiomyopathy. We can actually find the genetic reasons for it and actually find, these little biohacks that help us to bring it around. So it's where I'm kind of the most passionate, where I spend most of my time. In my clinic these days is actually taking care of these really complex, chronic, long-standing diseases that have failed all traditional therapies.
Sure. One of the things that I see in practice is the problem of classifying somebody with a mental illness when we can't come up with the cause of an organic complaint or problem.
Sure.
So I know you've seen the same thing. I see people diagnosed with depression, anxiety, personality
Yeah.
disorders, and they come in and they usually have an underlying
Yep.
complaint of pain or fatigue or brain fog, and
Yep.
it's sort of very confusing. So tell me how you start to dissect these cases, and how do you peel off that label of depression, anxiety, or
Yeah.
other mental illness?
Just about every person who walks into my clinic, again, I have a kind of a specialized practice where people come to see me from far away. Frequently, they've seen a lot of other people. I'm usually around doctor 6 or 8, somewhere in there, that actually does an evaluation. It's very typical. And almost always, they have been labeled as a hypochondriac and sent for psychiatric counseling, because people get to the point where they're outside of the realm of what is maybe a known clinical syndrome. And the symptoms don't make sense to physicians. They don't fit into the normal categorical box of, of a particular illness. So, I've been looking for a hypochondriac now for almost 10 years, and I haven't been able to find one yet.
Well, hypochondriasis is a real diagnosis. I mean, so
It is. And I'm sure they exist. I just haven't seen one in my clinic yet.
Okay.
Every single time I get to the point where I really feel someone is a true hypochondriac, I do a little digging deeper, and I can usually find an answer for it. Now, I absolutely believe that there are people who revel in disease, who exaggerate their symptoms, who feel some comfort in having excuses, and they, let the disease limit them. That's absolutely true. But as far as, somebody who really is trying to get the answers to a particular symptom, I've never seen it yet. So, but I do see all the time that people have been referred to psychiatric counseling because people don't know where to go next. Right. So in my clinic, what we do is we, spend a lot of time talking. When I have a really complex patient who's come in from out of town, traveled across the country to see me, we usually talk for 3 hours, and we do a pretty extensive, intake paperwork. But then I just kind of let people go in their own direction. And very frequently, when they do that, they'll start coming up with these these remarks and these insights into the disease that are occasionally profound. And we'll start sometimes ferreting out very small little details that might seem very superficial at first, but actually give us clues as to what the underlying pathophysiology might be. For example, the onset of an illness might have been after they were in the tropics and they contracted some kind of virus, which might have precipitated an autoimmune condition. Very frequently, it's after a particular medical intervention. That when they were given a surgery. And some sequelae of that actually led to it. Sometimes there's a very insidious, say, hospitalization in childhood, which would lead you to a diagnosis of an autoimmune disease you never would have thought about before. By understanding the interrelationship of different autoimmune diseases, and especially with the major histocompatibility system in the human leukocyte antigen complexes within the body, where you have different ones that are associated with different autoimmune diseases. So a lot of times, the very insidious little kind of clinical clues are what we need. But then we do a full evaluation. We look at hormones, we look at nutrients, and we kind of take that as like the top layer. And initially, when I would address all those issues and I wouldn't get the answer to the resolution that I need, that's when I'd look deeper. Now that I've been doing it for a little longer, I can usually spot what something is a clear genetic disease when they're off the normal presentation patterns that we see, and I can usually spot them right away. And I usually know earlier on in the case where I need to go ahead and get genetic testing, kind of go to the next level.
Great. Now, as you start to peel the onion on some of these cases that sound pretty complex, what's your first go-to? I mean, obviously you're getting basic laboratory work done. You've done a thorough history and physical. With genetic testing, I think a lot of folks out there are thinking, 23andMe, and that's going to give me, or Ancestry.com. I mean, we're talking about some pretty in-depth genomic analysis. And kind of talk to folks about what the difference is between something like 23andMe and what you're getting at the clinical level.
Sure. So 23andMe, it can be a very effective test for looking for, say, genetic, ancestry kind of work. But what you're looking at is literally specific, we call them SNPs, single nucleotide polymorphisms, which are known and highly, kind of common, defects in these genes. You don't pick up the de novo genetic errors. And when you rely on those, you miss a lot. You can have a totally normal, say, MTHFR gene through SNP testing, and because of a de novo variant in that gene, or because of a transcriptional error that you can identify with the post analysis statistical work that we do with the computers, you can actually have a totally dysfunctional gene. So just a simple screening test like 23andMe, when you have hundreds of genes or thousands of genes to look at, you can make some pretty significant conclusions about ancestry. But when you're looking at a very, very specific disease process, very frequently you will either, the information will actually be harmful because it'll look normal even when it's not, because other genetic anomalies can occur within that gene. So you can have what looks like a totally normal gene, the SNP isn't there, but the gene is still dysfunctional.
Okay. So what sort of lab work is required? I mean, you're looking at...
So this is not something I do for a normal patient, but these
Gotcha.
particular patients, when they have long-standing, deep genetic disease, the only thing I consider to be a reasonable evaluation is 100% full exome testing of every single protein encoding gene in their entire body. With next-generation analysis, where you actually get the structure and the function, including all de novo variants that have ever existed in that gene. And then this is proprietary kind of stuff, but then you actually go back over that, examine those data sets with computers, and you can actually figure out some indication of transcriptional anomalies within the genetic code to see even when that might have missed it.
Okay, great. And what sort of costs are we talking about? I mean, most patients come in not expecting to pay more than a few $100s for labs.
Yeah. Again, this is not the kind of thing we run on a normal patient. When somebody needs this kind of work, this kind of analysis goes into the thousands of dollars. Mm. And then, because we're in the early stages of it, it literally takes me, between 5 and 10 and 15 hours of research to really figure out what to do with one of these cases. So you have to pay for that time too. So there's a very significant financial investment. None of it's covered by insurance. The company that used to do this to cover insurance, they went out of business because they weren't getting fair reimbursement from the insurance companies. And we're kind of at that level, right, where we're making this transition at this point in our lives from this population-based medicine we've been doing for years and using pharmaceutical drugs to start, treating some of the symptoms and slowly start bringing in some of these more we call personalized medicine type tests. We're actually elucidating the actual underlying biochemical and genetic contributing factors to disease. And there aren't, well-written protocols at this point in time. So among the physicians who do it like myself, it takes a huge amount of investment in our time and in our effort to do it. But when somebody has, been to the big major academic centers, they've seen the top specialists in their field, they've tried the really expensive pharmaceutical drugs, and they haven't gotten any relief, usually people are willing to do it. And when they do, it surprises me how often we find really, effective treatments for them.
All right, I know we're trying to tail off here on some of the functional genetics, and we're going to save that for another day. But for right now, let's have a conversation around the basics of dealing with neuropsychiatric illness.
Sure.
From a functional point
of view. And again,
I'd
love to come back at another time and go really deep into the full functional genetics, but that would be another podcast. For right now, I agree. That's going to go to the other side of it.
Okay, so talk to me a little bit about some of the cases that you see and how you apply basic functional medicine to them.
Sure. So somebody coming in for, say, a neuropsychiatric type illness, let's just talk about what usually happens to a patient in that particular situation, right? They're feeling a little anxious. Maybe they're feeling a little depressed. They go to a physician, and the physician basically goes through a bunch of criteria. They go that they've been taught, usually as a mnemonic in medical school. SIGI CAPS is one that comes to mind. And if they meet the criteria, they therefore are, diagnosed with depression, and they're put on an antidepressant medication. The question for me is always why? Why are they depressed? Sometimes people are depressed because they're, it's a spiritual issue. Sometimes they don't have a peer group. Sometimes they don't have anybody to talk to. And very frequently what you find is that people have symptoms simply because they're sick. Either they have a functional abdominal disorder where their gut is not healthy, and that makes people anxious for a lot of reasons that we can talk about. Very frequently they're missing key nutrients within their diet, and that leads to people having psychiatric symptoms. And very, very frequently, especially with today's youth, it seems, we see people with massive hormonal abnormalities, which lead them to psychiatric illness. So when somebody walks into my clinic, one of the first things that we're going to do at any point in time is try to rule those out. Day one of medical school, I think, they taught us about pellagra. Remember learning about pellagra? The 4 Ds, right. Dermatitis, dementia, diarrhea, and death. It's caused by deficiency of vitamin B1. And before people get horrible rashes over their body, or before they get horrible diarrhea, usually they get a little bit of cognitive changes. They just don't have the mental acuity, they don't have the recall, they don't have the mood, and they start becoming a little depressed. And that's something I see in my clinic all the time. So somebody comes in, we ask, hey, you get any rash? And people with pellagra oftentimes have a little bit of a very insidious kind of rash, maybe on their anterior chest. Sometimes it comes out just after a shower. Sometimes they're itchy in the back of their scalp. Sometimes a little bit on their wrists. And oftentimes they'll have a little bit of loose stools. It might just happen episodically. People redefine these characteristics as saying, oh, well, you have a little bit of diarrhea every once in a while, some loose stools because you're anxious. And very frequently it's simply pellagra. It's one of the oldest nutritional diseases that every doctor in the world is supposed to use. And when people have a lot of gastrointestinal inflammation, thiamine, vitamin B1, is really not absorbed that well. So a lot of times we'll have to put them either on a lipothiamine or benfotiamine, which is a highly absorbable thiamine. Sometimes even give shots. And it's amazing that, a lot of times this simple nutrient supplement will, dramatically improve their psychiatric well-being. Women, especially because of the lack of green leafy vegetables in diets, will oftentimes not be able to metabolize their extra estrogens, and they get into this estrogen dominant state. And then, so if their psychiatric symptoms in a young, high school, girl were to peak with her menstrual cycle, very, very frequently what you'll see is that hormones might be completely and totally out of balance. And she'll have heavy menstrual cycles, she might have a lot of bloating, she might have emotional liability around that area. And if you support her and change her diet or give her specific supplements that are specifically targeted to reduce the number of estrogens and then get balance between progesterone, estrogen, and testosterone, very frequently her psychiatric symptoms will resolve even when she's not on her hormones. As part of that, because this all happens in the liver, when your liver is competing for and working really hard trying to break down these estrogen metabolites, your body often won't make a substance we call oxaloacetate. And this oxaloacetate is a necessary scavenging chemical that pulls glutamate out of your brain. And when people have excess glutamate in their brain tends to race, they have panic attacks, sometimes they'll have some migraine headaches, they'll have anxiety, they'll have insomnia. So one of the easiest things that people can try, because it really can't do anything bad to you, is obtain a little oxaloacetate. It's sold under the name Benadryl, and you take a couple when you're having some symptoms, and there's a little sublingual capsule. And then if you were to eat that oxaloacetate, it actually goes to your brain, goes right to the blood-brain barrier, where the glutamate builds up. You get a simple chemical reaction from glutamate into alpha-ketoglutarate. It turns the glutamate into a water-soluble substance. You pee it out, and people get dramatic reductions in their symptoms. Panic attacks go away, insomnia goes away, and they do a whole lot better. So those things are what we always try to fix first. And then, of course, we start looking at people's gastrointestinal function. One of the causes of anxiety is the lack of a healthy gut that is metabolizing foods normally. So that becomes irrelevant too. Do you want to get into talking about that at all? Or?
Well, yeah, I think it's important because there's so many people here that are running around on neuropsychiatric medications, including some of our listeners and viewers. And by default, they go and they see their internist, their family doc, and boom, they're suddenly on SSRI or some other neuropsychiatric drug. And there's side effects that come with these drugs. And so what you're telling me is there's a certain percentage of these folks that have some sort of either malnutrition or
without a doubt,
gut dysbiosis or some other issue that's underlying causing them to feel the way they feel.
So, this is all over the medical literature right now, and people are talking about it online quite a bit. But this interplay between, gastrointestinal function and healthy, gut metabolism and brain function is pretty discrete. And the answer is, on an evolutionary standpoint, right, a teleological perspective, why in the world would people have anxiety disorders? How are they facilitative for health? How does this help, the mammalian organism, the human organism, maintain itself? And the reason is when you have horrible digestion, what you're supposed to do is run through the forest and find the herbs and find the vegetables and find the foods you need to make your gastrointestinal better. So rather than sitting around your TP, in pre-industrial times or whatever structure you were living in, you would walk through the forest and you would try to fix your gut. You would try to fix the health of your body. So now people no longer do that. They run to their physician. and their physician doesn't know much about nutrition. Their physician doesn't know how to make their gut do better. So what they do is almost always put them on a psychiatric drug. So when you start looking at the gut health, so there's a lot of different mechanisms in play, but probably the most common one is that you need plant-based fibers, these things we call resistant starches, which go into your gut, and there's a fermentation reaction, just like Saccharomyces cerevisiae might chew up a sugar and then create alcohol as a byproduct. Your bifidobacterium within your gut metabolizes, ferments these resistant starches, which are plant-based fibers that your human enzymes can't break down. And then as a byproduct of that, you get short-chain fatty acids, which feed the colonic enterocytes, keep your gut healthy, and also create a substance called 5-hydroxytryptophan. 5-hydroxytryptophan is serotonin, and 95% of the serotonin in your body is actually created in your gut. It was a little bit of a misnomer and a misunderstanding back in the 80s when people were taking a lot of 5-hydroxytryptophan and the SSRIs came out, that they made this big claim that 5-hydroxytryptophan could not have been effective as a psychiatric substance because it didn't cross the blood-brain barrier. And that's absolutely true. So one of the reasons the SSRIs were able to get a foothold was because everybody was taking this 5-hydroxytryptophan, they released all this information, this medical literature that said it couldn't cross the blood-brain barrier. But what happens is the 5-hydroxytryptophan doesn't leave your gut, it stays within your gut. It actually interacts with receptors primarily found on the vagus nerve. And then the vagus nerve itself will actually send these neurological impulses up to your brain that have this tremendous calming effect, and people feel relaxed. So a lot of times when their gut is dysfunctional, you can try to fix their gut, you can try to change their behavior, you can try to get them eating healthy foods. The shortcut you can use in the short term is just feed people 5-hydroxytryptophan, 5-HTP, and it can become incredibly helpful to them to help reduce their anxiety and help relieve some of their depression.
What do you think are some of the biggest side effects that you've seen in the patient population that comes to you already on neuropsychiatric medication?
The first thing I got to say is I'm not anti-neuropsychiatric medication in any way. People struggle, people are depressed, people kill themselves. Depression is a serious illness. And there absolutely, unquestionably, is a time and a place for using a drug. The first thing I do is I just talk to people. And when I talk to them, I say, hey, did this stuff make your life better? Or did this stuff make your life worse? It's amazing to me when you just ask that opening question. People will often say, I don't feel any better at all. I feel worse. I have side effects and I don't feel better. My life isn't better because of it. So you're obviously on the wrong track, right? And that's pretty common. Of course, there's a reason they're seeing me. If they're feeling better, they're not going to see me. The other side of it is people sometimes, will come to me and say, hey, I feel a lot better on this. And most physicians in that situation will just leave you on it, And my perspective is a little bit different. If you leave somebody on it and you leave them on those particular drugs for a long time, say it's an SSRI, the SSRI drugs work for a little while, usually 6 months to a year, and as the serotonin levels go up in the synapse, you increase serotonin receptor density, and you need a higher level of serotonin to elicit the same level of control of the depressive symptoms. That process takes somewhere in the vicinity of 6 months to a year. If you leave them on for longer than a year, the drug no longer has its intended effect. And if you try to take it away, the end effect of having been on that drug is to typically propagate the neuropsychiatric symptom you're trying to treat. The same thing happens with the benzodiazepine, where over time you'll actually become more anxious while you're on it. So when somebody comes into me and they're on a particular drug already, one of the things that I'll try to do is, make a plan to get them off of it. And, the reasons for that are pretty good. It's because if they've been depressed in the past, they're probably going to be depressed in the future. So we try to find a window to where they can withdraw off the drug, and then that becomes like their magic bullet, right? That's the thing that made their depression that much better. So we save that for the future, and we can utilize it again. If you leave that person on that particular drug, you can no longer use that drug, right? It's not available when they become depressed again. So now you're adding a second drug. And now you're adding a third drug. And very frequently when somebody comes in to see me, they've already been on 3 or 4 different drugs. And as we talk to them, maybe 1 or 2 of them had been effective at some point in their life. The other couple just got stuck on there and weren't discontinued because it was easier just to add another one on than take one off. So that's kind of one of the struggles that I see on a regular basis. And we need to determine exactly which drugs to withdraw first. And we do that by supporting everything else, supporting the nutrition, supporting the gut function, balancing out the hormones, and then slowly start pulling some of the drugs away that make the least sense for them to be on. And by doing that tactic, very, very frequently, and it's amazing. This last week, I've had 4 or 5 people come in who have been doing this for years. They're functioning at a higher level than they ever have. Very frequently, they were on 3 or 4 drugs. Now they're on typically 1, and their baseline function is dramatically higher than it's been in any time in their recent history. So it's been pretty rewarding to kind of work with those people and do that.
Yeah. So talk to me a little bit about the role of nutrition for you. How do you actually analyze whether or not these people are malnourished and that's what's maybe causing their mental illness or symptoms of being mentally ill?
Sure.
And versus a true gut dysfunction or a malabsorption issue?
So it all depends on the clients. We don't have any kind of standard workup that we do. I try to get a pretty aggressive blood panel looking at hormones, inflammatory markers, autoimmune markers, as a baseline on everybody, and then only when it warrants it, and depending on what the patient's budget might be as far as doing additional testing, do we then go on to do, say, an advanced stool analysis looking for digestive issues, or characterizing the gut microbiome. And then on top of that, one of the more helpful tools I've ever been able to find is doing some snip testing, these genetic analysis panels that look for specific neuropsychiatric syndromes that we can do an evaluation on, and we can actually see exactly, which underlying genetic factors might be contributing to that person's specific symptoms. This is where we kind of get into this big change we're undergoing in society. We kind of alluded to before, right? Where we have the traditional way of doing things, the traditional diagnostic, the DSM manual that kind of tells us exactly how to codify a specific psychiatric illness, then tells us exactly what psychiatric drugs might be indicated in that illness, compared to what we call now is this, precision medicine or personalized medicine, which is what I prefer, where you're kind of redefining these syndromes into their genetic underlying contributing parts. And when people start playing with this, and I have a bunch of friends of mine who use these now, you start seeing this much higher correlation between the genetic syndrome and a person's symptoms, as you do in the traditionally described anxiety, bipolar, schizophrenia type, diagnostic classification system.
So are we at the stage yet when you can just see a set of genetic tests and be able to guess what sort of symptoms these patients may be expressing?
When a client comes into me, now that I've been using these tests for about 7 years, and they are describing their symptoms, my brain does no longer go to, does it sound like anxiety, depression, bipolar? My brain instantaneously is asking me, is this an SLC6A4, a CACNA1C, a BDNF, a GRK1? So I'm specifically looking at the specific gene in the tapestry of how I actually look at neuropsychiatric disease.
Gotcha.
And then I'm either making a decision on what pharmaceutical drug they might benefit from if it's severe and we're worried about, say, somebody who's acutely suicidal and we need to stabilize it immediately, or I'm taking my knowledge of the underlying biochemical pathway and figuring out what hack we might be able to use to attenuate those neurological symptoms and do it that way. And again, there's no philosophical part I have against pharmaceuticals. Pharmaceuticals are wonderful, right? And especially in psychiatric disease, occasionally we need to use them. But again, the psychiatric drug tends to perpetuate the treatment you're trying to give. And if I use a non-pharmacological treatment, we tend to get much better long-term remission. It just takes a little longer, and we need to have a patient who's a little more engaged in the process.
All right. Well, one tool that I've used in the past for folks who've come in and who weren't big fans of being on neuropsychiatric medication has been some pretty strict dietary changes,
Sure.
which I see have been helpful, as well as periods of fasting. Can you talk about what the mechanism might be around this whole idea of fasting? Because a lot of folks that we've had on even short 1, 2, 3 day long fasts report back significant feelings of feeling better, clearer thinking, and overall mood shifts to the positive.
Sure. And there's several probably underlying mechanisms for that. Number one of those is when you're undergoing a period of fasting, any autoimmune process that's going to be mediated by the consumption of a food is largely going to attenuate. So you actually get a reduction in inflammation from a reduction in the autoimmunity. That plays a role in some of these clients. The timeline you're given, 2 to 3 days, this usually doesn't happen, but it can in some cases, where whenever you're eating a particular food, there's a bacteria that likes to take care of that food also and can grow. You actually get this dysbiosis, these bad bacteria in your body that can release these inflammatory, immune provocative, and sometimes directly, neurologically stimulating chemicals, which actually makes you feel bad. Those people typically need to be off those foods for 5, 7, even 8 or 9 days before they actually start feeling a whole lot better. And part of the reason I think a lot of people feel better when they undergo the fasting is that when you stay away from the carbohydrates, you can actually bring your insulin levels down, and your body can actually go into its ability to break down your fat cells and actually make free fatty acids and ketone bodies. Sometimes those are actually a much better fuel source for your brain. Do you have any other mechanisms that you're aware of?
Well, I think you mentioned the ones that were critical. Number one, obviously, is elimination of things that could be pro-inflammatory in the nervous system, reduce the impact of an immune response.
Sure.
And ultimately, ketone bodies certainly burn clearer in the brain.
Sure.
I think that there's, I also think sort of societally, when you stop ingesting something, your body's able to go about basic repair mechanisms that have sort of been put on hold.
Without a doubt.
Because so much energy is putting into digestion. But in a nutshell, I think fasting is one of the best tools we have out there in medicine, and it's completely underutilized. And in fact, I talk to a lot of patients who have benefited from fasting, and they ask me, well, why hasn't anyone ever talked to me about intermittent fasting?
Yeah.
Or and it's just not something that we were educated on until we went out and looked for that kind of.
Without a doubt, and there's one point I want to make about that, which is people see this fasting as this radical idea, right? And they don't realize that perhaps the problem is our society has wrapped itself around this concept of 3 or even 4 meals a day.
Yeah.
Where when I travel around the world and I've been to other countries, it's somewhat typical for some of these people in pre-industrialized societies to eat a single meal a day. It's a natural state. So the human body is supposed to go into periods of fasting.
Right.
And it's only our kind of unique culture and our affluence that we have in this country where people constantly think they need to be in a constantly fed state.
Right.
And, it's so ingrained in us that this is normal, even when it's not, that people initially, have this knee-jerk reaction against it. And when you describe, hey, this is normal for people in most countries, this is done in pre-industrialized societies, and it's just a normal part of human existence. Your body should be able to go an entire day or even a couple days without eating food.
Yeah. Based on the hunter-gatherer metabolisms that we basically have come from, there's times you feast, and then there's going to be sort of a famine period where you're in forced fast, and you still have to function. And so a lot of people think, well, if I don't eat, I can't function. I can't do my job. I'll get a headache. I'll whatever.
Yeah.
And there's so many people who have been accustomed to having certain things in their body, whether it be coffee or caffeine or sugar, that when they withdraw from that and they have some dysphoria, they're averse to that, and they won't let the time go by for them to pass through those symptoms.
That same thing goes on with the fasting issues. Very frequently, people will be eating these carbohydrates. The carbohydrates stop the die-off reaction of these bad bacteria. When they actually finally stop eating these foods, they actually feel worse, and they need to go through this transition phase before they actually start feeling better. And very frequently, these conditions self-propagate because people won't go through that period of time.
Yeah. Talk to me a little bit about other interventions that you use with folks that have sort of come in with the anxiety, depression, personality disorder sort of diagnosis.
Sure.
When it's something more organic. I mean, what other tools do you have besides this mind-gut interaction?
So, one of the things we do is we do these profiles of genetics, looking at these snip testing for the genetics. And, based on each one of these, you can actually determine why somebody is having the symptoms they're having. And then you can actually find specific interventions. So I think one of the ones I alluded to before is this thing called the SLC6A4 SNP. And what happens with an SLC6A4 is that people, when they're born, the little enzyme that breaks down serotonin within the synaptic cleft of their brain is actually dysfunctional. So from the day they're born through their entire neurodevelopment, they have extraordinarily high levels of serotonin in their synaptic clefts. And what happens to them is they start having a very, well-defined, kind of disposition about themselves. They usually are not all that happy in general. They're usually not really popular kids. they're usually looking for long-term gains, and very frequently the kind of person who might actually go and say, get a college education because they feel good about long-term gains, and they're not looking for short-term interventions. And they're not necessarily always depressed. Sometimes people have this, and they're just, this is part of their disposition. But what's important about them is it makes up around 10% of the population at least, is that those people, and that's in the pure homozygous state, right? 2 bad copies of the gene. The heterozygotes have partial, similar responses than the homozygotes or the normal ones. But in the people who have the really bad part of it, or the more significant part of it, it's about 10% of the population. And those people will almost never, ever respond to an SSRI drug. You'll talk to them and they'll have been placed on one that might have been on for a couple of years and say, no, it didn't make any difference at all. My doctor told me it made a difference to me. It didn't make a difference in the slightest bit. And the reason for that is that SSRI inhibits that exact same enzyme that is already not functional in their bodies. So when you get the gene and you understand that, it becomes very intuitive that this drug is never, ever, ever going to work on them. One of the amazing parts about this is that these people have a phenomenally high level of PTSD. So wounded warriors who are returning back from battle who report PTSD, and they have these visual, intrusive memories of what happened to them, almost universally, or with a high level of statistic probability, are more likely to have this genetic combination than somebody else in the population. And when you meet somebody, almost universally, that person is going to report some level of PTSD. It might have been a car accident. It might have been some, bad breakup with a boyfriend. It might have been a traumatic event. It might have been an assault, but they very, very frequently have a PTSD. So the question becomes, what do you do about that? The primary antidepressant that we use in our society doesn't work in them, and very frequently they have ongoing psychiatric illness. So there's a couple drugs that you can use that work on it, but one of my favorite ways is something we already talked about, which is, that's the kind of person who might actually get the 5-HTP. You can actually get them to calm their brain down, make them feel sensitive, make them feel reassured, and actually works really, really well in them. That's the only way you can actually engage a serotonergic-like response within their body.
Well, when you look at the whole picture, how does sort of the endocrine system play a role in some of these neuropsychiatric conditions? Because I know we talked a little bit about that in our other cast. Talk to us a bit about how looking at hormones for you makes a difference in how you treat these folks.
That's that's kind of like the first layer of the onion, right? We look at the hormones, we look at the nutrients, we kind of rule those things out, and then we go into the when that part is taken care of, and then we get rid of the gut disorders. That's when we usually go into the genetic side of it.
Okay, so you would have already cleared up, if they had a thyroid issue or if,
100%.
Their
That's
testosterone was
the
out
first
of whack.
level, and
Okay.
we always take care of that as the initial
Gotcha.
part of it, and then go into the psychiatric stuff later.
And then how do you go about talking to patients about transitioning off of meds if that's appropriate? I know that there's, hundreds of psychiatrists out there that this is their bread and butter work, and they are the masters of psychopharmacology.
And this is where you get into some very dicey politics, and you get into, some really, really, really serious kind of stuff. Because people have the highest level of suicidal ideation and suicidal behaviors when they're withdrawing. Being on a psychiatric drug and being stuck on it it's a really scary thing. And a lot of times when you've already done this and you're trying to withdraw, you're going to have a harder time than ever before you were placed on one. So the way I do it is this: I don't ever stop anybody off their drugs. And I specifically counsel them to, continue to see their psychiatrist. And what we do is we provide this peripheral support. And we then just start, looking at all the genes. And we talked about the SLC6A4. There's lots of other genes with very, very specific interventions. We can talk about, if you like, how you actually start tuning down some of the symptoms from these. We provide that support. And only after we provide that support and get them more balanced, get their hormones fixed, get their nutrient levels fixed, we then encourage them to go back to the psychiatrist and have the psychiatrist do the withdrawal. When they don't, oftentimes I'm stuck in that position where they want me to do it, and it's something we're willing to do, people. And the answer is, one drug at a time, and typically way slower than people imagine. So say something like an SSRI, for example. That drug has a biological half-life of a month to 2 months. You can stop cold turkey right now today, and you won't even start to go into withdrawal if you're a slow metabolizer, especially for 2 months. So by that time, usually people have no concept that that's even what's happening in their body. But very frequently I see that, right? People stopped the drug a month ago. They think that they're completely off of it. They're coming in my office and they're, having a horrible time. They don't know what's causing their symptoms. We found out they stopped an SSRI, say, 4 weeks or 6 weeks previously. So very frequently in these drugs, depending on how long they've been on it for, depending on what their genetics show in their brain, we need to get off them very, very, very slowly. So very, very slow, very insidious process with open communication, frequent visits over periods of, months to sometimes even years.
Mm. Well, the waters are kind of muddy around some of these SSRIs. We know that in children, young adults, that there's an increased risk of suicidality when they start to take these medications. And you're now also saying that coming off these medications, there's another bump in that risk. So what purpose overall do you see the role of neuropsychiatric meds? I mean, are they for emergent situations? I mean, I'll be honest with you, I want to say 25 to 30% of the patients that I see, and I consider that a good sampling of the general population, have had active prescriptions for SSRIs.
The most recent data I saw, and again, I'm not quoting specific numbers here, but somewhere around 30% of all kids graduating high school are already in a psychiatric drug.
Wow.
So, that's the question is, do 30% of the population truly have neuropsychiatric disease? Is this simply a manifestation of something else going on in our society?
Right.
Is it expectations? I don't have answers to any of those questions, Sean.
Sure.
Those are large questions for society, not for us. The only thing I have answers for is the person who's in front of me. And that's where I typically, put most of my effort and time. What I can tell you is this. I recently had a client come into my office who was put on a prescription for an antidepressant for some pretty minimal symptoms that he had, and now he wants to go and become a pilot, and he's not able to become a pilot. The FAA won't approve him because he's been on psychiatric drugs in the past and he has a psychiatric history. So even placing somebody on a psychiatric drug, you can argue that there can be long-term harm. He's prohibited from a career. Now, there is a process that he can follow. Usually takes, from what I've understood, 1 to 2 years in order to actually get permission to proceed with his pilot's license. But this is something significant. About 3 months ago, I had somebody come in, and they had actually graduated, from an Ivy League institution, and they were trying to get into the FBI. They were rejected in the final stage of applications, because they had been on psychiatric drugs in the past.
Wow.
So, forget about all the other repercussions that can occur from giving a psychiatric drug and the changes in somebody's brain chemistry that can result from them. But, because of these possibly archaic laws and these guidelines that different institutions have in our country, having ever been on them is truly, not socially stigmatized, but legally stigmatized,
right,
to where they're prohibited from having certain career options based on having used these drugs in the past. And again, I'm not against the drugs. There's a time and a place for them. I think it's very hard to argue that when 30% of an entire population is placed on these drugs, that humans just need these drugs intrinsically. Is that what we're saying?
Right. No.
I don't have the answer to that. No. What I can tell you is this. When somebody comes into my office and we do our workups, we fix the nutrients, we fix the hormones, and we figure out exactly what the genes are. We provide them with, some supplements that kind of work around some of the specific physiological abnormalities. They typically have a better result than if they're on a psychiatric drug, especially in the long term rather than the short term.
Sure. So in general, as we bring this to a close, tell me a little bit about how or what you would share with patients out there who are on neuropsychiatric medications now, how they could go about requesting some basic testing to see if there wasn't some underlying cause for the symptoms they originally were treated for.
Sure. So, one of the things that, helps me the most is doing the genetic testing. You need a provider who kind of understands how to use that. And most people are using that genetic testing specifically for deciding what pharmaceutical agent to utilize, right? Not actually looking at the underlying cause and try to figure out how to fix it nutritionally. But there are physicians out there who do that, and that's one of the tools that really makes my job a whole lot easier. By determining the specific gene, figuring exactly what the gene is, what it does to the body, and then finding a hack to make those symptoms become way less problematic for that particular patient by using specific nutrients.
Right.
And that's the technique I use for most of this. It's kind of the cornerstone of how I address these neuropsychiatric issues, and typically it's very effective.
Great. The other issue is a lot of folks, I mean, genetics obviously is critically important, but the other pieces we mentioned were these endocrine issues,
Sure.
imbalance in hormones, other nutritional issues, and of course gut problems, dysbiosis and otherwise. So ultimately, a lot of clinicians who don't practice functional medicine, like they're just handing out a med. They said, listen, you can't sleep, you're sad, you had a breakup with your girlfriend, here's some generic Zoloft. I mean, that's usually what I'm seeing out there in the common allopathic practice model. So, what are because you have to empower the patient in order for changes to take place. I mean,
Sure.
So they need to ask for all these things. And some people who have a layman's knowledge of medicine, they might not even know where to go. What's that first step? So kind of what do you think that first step would be?
So, one of the big spikes you see in people being prescribed pharmaceutical drugs is women, usually between the ages of 40 and 55 years old. And there's obviously a major thing going on in a woman between 40 and 55 years old. She's losing her hormones, and her hormones are becoming incredibly imbalanced. And that's something that we see all the time. If you actually look at the number of antidepressants and anxiety medications that are prescribed, in women, it's almost always in that time period. So in those particular people, you get into the whole concept of either balancing those hormones when you're either progesterone dominant, which leads to one constellation of symptoms, or estrogen dominant, which leads to another constellation of symptoms with nutrients, or if that person is amenable to it and it's an option for that particular person, is potentially moving into bioidentical hormone replacement therapy. One of the things that happen when people get a little older, they lose a little progesterone, they lose their executive function, progesterone levels are a little low, they usually have problems sleeping, they're gaining a little bit of weight, they're becoming a little anxious, they're becoming less socially engaged, and by putting in at that point in time, they're usually, if they go to say their gynecologist or a primary care provider, they're placed on an SSRI plus or minus a benzodiazepine or a sleeping pill to help them go to sleep at night. Those same people just simply placed on progesterone do dramatically better, and they have a huge reduction of symptoms, and then they have all these other metabolic benefits as well, not only the neuropsychiatric component of it.
Yeah, progesterone is a very powerful hormone, and I think a lot of people can benefit from it. Absolutely.
I have women who have literally been expressing psychotic symptoms, and then they had people wanted to place them on antipsychotics, including psychiatrists who wanted to put them on there. Who came into my office and they said they did not want to be on any drug like that under any circumstances. We do an evaluation on them. We look at their hormones. We see that they're massively imbalanced in their hormones. We give them a little progesterone, sometimes some other little hormones, and next thing you know, 100% resolution of all their symptoms. So you kind of wonder to yourself how many of these people who are given these powerful psychiatric pharmaceutical drugs simply in lieu of a natural hormone, with a very limited side effect profile at all when you're talking about bioidenticals versus pharmaceutical hormones.
Right, absolutely. All right, well, I know our time's coming here to a close, so I just want to again thank you, Jamie, for being here. We're definitely going to have you back. I definitely want to uncork the bottle of functional genetics and talk about how a deeper dive into the genes of individuals can really provide for us some optimization of this personalized medicine, which we have espoused to be really the next generation of healthcare. And
I truly believe it is, and it's one of the most powerful tools I've been able to find, at least for my specific patient population that I see the most.
Great. That's wonderful. Thank you, James Raniolo.
Thank you.
And this is Dr. Devlin closing out another Medicine Wheel. We look forward to seeing you again soon, and we look forward to having James back on the show. Take care.
The Medicine Wheel encourages all of our listeners to subscribe to our newsletter and podcasts as we continue to explore the world of medicine, bringing you up-to-date health and science information. The Medicine Wheel invites our listeners to email us any newsworthy stories or topics they wish to explore further and discuss on the podcast. For more information about the Medicine Wheel, please visit us at our website, www.themedicinewheel.org, and on Facebook, and finally on Twitter and Instagram at The Med Wheel.
In an effort to support access to integrative medicine and functional medicine options for those in need and education for those who need information, please consider donating to Project OmCare, 501c3.org. Please go to our website, www.themedicinewheel.org, to learn more.
Thank you again to all our local sponsors, Grateful Gardens, Lighthouse Coffee, and Dorinda's Chocolates, which represent some of the best organic and appetizing options in the Reno, Tahoe area.
Lighthouse Coffee Shop is a proud sponsor of the Medicine Wheel. We are a family-owned and operated local coffee shop. Our goal as a business and a family is to cultivate community wherever we are. All of our coffee is ethically sourced, organic, and farm fresh. It's roasted in-house daily, guaranteeing you access to the freshest cup of coffee on the planet. We care deeply for our community and everyone in it. We strive to provide you with the best ingredients and most comfortable environment. Come and enjoy coffee with us. We are family, and we would love for you to be part of it.
Gerber Medical Clinic is proud to support the Medicine Wheel and medical education to improve health quality, nurturing the lifestyles of our listening community, enhancing wellness for all. Thanks again to Wired Insights and their talented team for making our podcasting dream possible.
In closing, we would like to remind all of our listeners, if you have a medical concern or diagnosis, you need to see your personal doctor without delay, and if needed, obtain a referral to a specialist. If ever you feel the health issue you have is urgent or an emergency, please call 911 and go to your nearest emergency room. Please do not take any of our physicians' commentary or our guests' opinion as medical advice, and always seek out medical care from fully licensed and appropriately trained medical professionals in your area. The information shared in this podcast is for general information only and should not be construed as medical advice, and understand that no doctor-patient relationship is formed. The use of this information and educational materials linked to this podcast and website are employed at the user's own risk. The content of this podcast is not meant to be used as a substitute for medical advice, diagnosis, or treatment.
This is the Medicine Wheel signing off for this week with a reminder to live, love, listen, and learn.